It's amazing that for a disease as old as gout, that we're still learning more and more about how to treat it better. And there's certainly been a lot over the last 20 years, which has made the lives of people living with gout, the lives of people treating gout, a lot easier. So one of the things is that we don't use the kind of heavy doses of colchicine that we used to use for treating acute flares of gout. And I think we all remember what it was like to give people high doses of colchicine and see the diarrhea and vomiting that happened as a consequence. So it's really nice to know that we don't need to do that, and it can work equally as effectively for flares of gout. Another key thing is really about trying to use colchicine when we're introducing allopurinol or another uric acid lowering therapy. We know now that if we keep a little bit of colchicine, 0.5 milligrams a day, going right throughout the escalation period of uric acid lowering therapy, and then for 6 months afterwards, we can prevent the kind of flares of gout that we can see happen when we do initiate uric acid lowering therapy. When we do introduce uric acid lowering therapy, leaching out all that uric acid, we can trigger flares as those crystals dissolve at the joint level. And so having that little bit of colchicine in there prevents flares from coming on. Another key thing has been about how we treat and escalate allopurinol to try and treat to target. One of the key things that happened 10 or 15 years ago was this idea of treat to target, that we would measure serum uric acid, figure out what kind of target we wanted it below, so below 0.36 for most people, but for people with tophi below 0.30, and then escalate the allopurinol or the other uric acid lowering therapy until we hit that target. We used to cap out a little bit with the amount that we were willing to increase the uric acid lowering therapy to, the allopurinol to, and we often used to stop at 300 milligrams, and we used to get suboptimal outcomes. But now we would say we can keep on increasing this until we reach target, as long as we increase it incrementally. And by increasing it incrementally, we avoid any risk of allopurinol hypersensitivity causing real problems. The times when we see allopurinol hypersensitivity cause real problems is when we start with a heavy dose and we don't have control over where that takes us to severe cutaneous adverse reactions or other allergy problems. One of the other things that's come up over the last few years, which we've become especially more aware of as the population in Australia has changed in terms of ethnic makeup, has really been about allopurinol hypersensitivity and HLA-B5801. We know some people have a genetic mutation that means that they're at increased risk of hypersensitivity to allopurinol, and we can test for that to try and avoid it from being a problem. Now, the people we really want to test for that the people with greatest risk are people of Han Chinese ethnicity, so there's a lot of East Asians come underneath that umbrella. There are a number of misconceptions about the way we treat gout. I think one of the oldest ones is about stopping uric acid lowering therapy when people get an acute flare of gout. There's no reason to stop the allopurinol or other uric acid lowering therapy during a flare of gout. It just confuses things, and if anything, it could make things worse. So we continue those right throughout and just add the acute treatment on top of that as well. Another key misconception really comes down to this idea of caps on how much we increase uric acid lowering therapy. And we know if we stop at 300 milligrams, then a big proportion of patients are just simply not going to get the benefit that they need from uric acid lowering therapy. So it's just a matter of keeping on increasing up until we hit those targets. One of the other key misconceptions is that you can turn gout around but with diet alone. It's very uncommon to be able to do that in people who have had clinical gout. And so really we're trying to get people to start medicines earlier than they would have done otherwise. It's not just a matter about trying to fiddle around with diet and without triggers. When someone has an attack of clinical gout, that gives you an idea about the uric acid burden underneath the surface and the idea that we need to try and deal with that. A treat-to-target strategy in gout has become the cornerstone of the way that we treat gout in modern medicine. And that's the idea that if we get the serum uric acid below a certain level for a given patient, we can leach out all that uric acid, create a concentration gradient to make sure that it leaches out of the body and that we don't have gout or the other consequences of excess serum uric acid in the body. When it comes to targets, we're looking at 0.36 for most people with gout, and below 0.30 for people with tophi, because they need that greater concentration gradient to try and actually dissolve the tophi away. One of the main reasons why people don't effectively treat a target is that they give up. They stop too early and they don't keep on going until they reach target. We know that the vast majority of patients, that if you try, 99% of patients can effectively reach targets, but it's about persisting with it. And we know that in everyday practice, that's not something that happens as often as it should. So setting those expectations up front at the beginning with a patient, trying to explain to them the benefits of uric acid lowering therapy beyond gout, and the idea that gout is a very treatable condition, and then going for those targets, keeping things regular, measuring that serum uric acid, and increasing it until we get below a certain level, below the target serum uric acid. That's a pathway to success. One of the key traps is really about allopurinol and chronic kidney disease. And it's an understandable concern given that allopurinol is renally eliminated, that if we don't adjust the dose appropriately, that we can create toxicity from allopurinol. Really, that comes down to the starting dose, not necessarily the capped dose. And we can go up to 900 milligrams a day, and we've seen that work effectively in trials. But for people with chronic kidney disease, it's about trying to reduce the starting dose and the increments, and that really depends on how bad the chronic kidney disease is. But we know that if we take those rules into consideration, set the expectations up front with patients, and work with them over the course of time to achieve those targets, then we can get good long-term outcomes for people with gout. And really, that's one of the most satisfying things. It's understandable that some patients might have some reticence about starting lifelong treatments. But I think that we in medicine are used to studying lifelong treatments for people, whether that be antihypertensives, statins, or other therapies. And we've become better and better at talking about them. In particular, when we talk about things like antihypertensives or statins, we talk about the long-term benefits. We talk about the changes that are happening in the body, and we talk about the pathways that we could take and actually trying to achieve something which reduces risk in the long term. And it's exactly the same with uric acid lowering therapy. If we can talk about not just about the benefit of reducing down flares of gout, but also about the benefits of preserving joints in gout, and also making sure that we improve long-term cardiovascular and renal outcomes, then those kind of things are things that resonate with patients, make them think that this isn't just about having to not deal with flares of gout, which is a significant motivator in itself, but also to try and improve their long-term health. I'm really glad that we're in an era now where there's a lot of easy to use information about these new approaches to gout. And the Q-Hub Medcast portal is fantastic in terms of the resources it's got there, really clear algorithms, lots of really useful information, things that you can use for patients as well. The Arthritis Australia website has a lot of really good information there as well, and stuff that's patients can relate to, and also some stuff which is relevant to specific cultural groups as well. The Staying Mover, Staying Strong program for First Nations people living with arthritis on the Arthritis Australia website has a specific pamphlet about gout as well. So if you've got patients who are Aboriginal or Torres Strait Islanders, that's a really great resource.